Good afternoon. My name is Erinn. My pronouns are they, them, and I'm with Project ECHO. Welcome to the Public Health Science ECHO, where the public has the opportunity to ask science-based questions for our public health team. For those joining us on Zoom, questions may be entered into the Q&A feature. For those joining on Facebook, please add your questions in the comment section and they'll be shared with our panelists. As a reminder, we expect all participants to keep questions and comments on topic, to be considerate, and to use language that is respectful. So for that, I thank you. If your internet connection does not support audio, you may join us by phone by calling the phone number we've entered into the comment box, along with a meeting ID. Closed captioning is available as well. The CC button is on the bottom of your Zoom screen, and thanks to our captioner. I'd also like to note that the opinions expressed in this session are those of the speakers and do not necessarily represent those of UAA, DHSS, or any of our ECHO sponsors. Our hub team should all be familiar faces by now, so in an effort to maximize our time together, we'll go ahead without introductions up top and instead let our hub team members introduce themselves individually during the session when addressing questions. So without further ado, Dr. Zink, I'll hand it over to you for today's presentation.
Great. Thank you so much for everyone for joining, and thanks to our information team for always helping to put together these slides. So I'm going to go ahead and share my screen. Remember, the Q&A box is in the chat box, and encourage you to start throwing in your questions so that we are all on the same page. Okay, so I'm just going to go ahead and display that. Erinn, you can see that okay? Awesome. Sounds good. Okay, so go through these quickly so that we have lots of time for your questions, because that is what we're here for. So a lot of red. We continue to have a lot of cases in the state. Remember that as the whole system becomes more busy and more full, cases are delayed in reporting. So it takes longer for, say, a hospital or a clinic to report in that data. It takes longer for tests to turn around. It takes longer for our team to upload that data. We're all working as fast as we can to make sure it's as timely and accurate as it can be, but there can be some delays. I think the overall trend is pretty clear. We got a lot of COVID spreading and a lot of places are exposed, particularly all across the state. So we've seen a 19% increase week over week. We have a total of 1,951 hospitalizations total. I'll go through the hospital data in just a minute. And new cases that were reported out were 573. Again, go to our dashboard and be able to look at the onset date rather than the report date to have the best accurate idea of what's happening in your community based on onset, to take into account some of these lags in the data, which continue to be there. So a bunch of different ways that we look at hospitalizations, and this is on our dashboard, and this kind of represents the total number of people in the hospital right now with active COVID, and these are reported to us from the hospitals themselves. And currently we have 121 people with active COVID in the hospitals at this time. This may not represent people who have COVID but no longer infectious, but are still suffering from consequences of COVID, such as had a heart attack or stroke related to it, or who may be in the hospital for really prolonged periods of time, including after including after they were infectious, but they're still requiring hospital care. So again, we're happy to talk through some of these data limitations, but these are kind of the estimate of what's happening in the hospital at this time with the number of people actively infected with COVID-19. It's 121 people. That's 13.1% of all of our hospitalizations are because of COVID right now. And currently on the vent are 28 patients in the States because of COVID at this time. We continue to see the percent positivity be quite high. Again, there can be some delays in this data and try to get it through as quickly as possible. But it's just a reminder that people should really consider symptomatic testing at the beginning of any symptoms. And then there could be a real role for additional testing, such as like before and after travel, certain congregate work settings. And thanks to many of the schools who are partnering to do kind of ongoing surveillance testing to just identify cases early so that we can keep our kids in school and keep our communities healthy and safe moving on. A lot of this is being driven by the Delta variant, which has become the predominant variant, not only in the state, but the country and worldwide. You can always follow along with our syndromic surveillance reporting to be able to see the current set of cases that we have and what variant of concern they may or may not be. So thanks to our team for continuing to share that. We've broken the 60% mark, which is exciting. So those residents 12 and above with at least one dose You know, we continue to move at the speed of trust and to continue to make sure that all Alaskans have the information that they need to feel comfortable about a decision to get vaccinated. We encourage you to continue to talk to your primary care provider, request a speakers bureau, and many of you are showing up here to have your questions answered, and appreciate that. You're also welcome to always send kind of private chats during here, and we're always happy to help in any way that we can. But it's great to see more Alaskans continuing to choose to be vaccinated. You can see on this bottom number that we've had kind of a 6% increase over the previous 2 weeks. But when you look at it, you know, in the beginning of July, the cases were really down, and then they've started to pick up a bit more in August. So it's not the same sort of drive that we had back in March when we're looking at the total number of cases, but we are vaccinating more people in August than we did in July, which is fantastic to see, as this is our best tool out of this pandemic. Here's the statewide data for the 12 to 18-year-old, and we've really seen a pickup in these vaccine numbers as well. So 45% of all of our Alaskans between the ages of 12 to 18 have received at least one dose, and 36% of the 12 to 18-year-olds are fully vaccinated. So really thanks to everyone who's considering vaccination. I'll talk about that just a little bit in a minute, but you can also see that we see a lot of variability across the state in our vaccine uptake rate in that first dose as well as fully vaccinated. So kudos to the communities that are really kind of helping to minimize this disease on their families and their communities. So a question we get a lot is like, well, kids aren't really impacted by this disease as much. Like, why are you encouraging kids to get vaccinated? A couple different reasons. So COVID-19 vaccination is the best way to protect our children from this disease. So when the CDC looked at the kids ages 12 and above and looked at your risk of getting COVID in that age group, as well as the risk for vaccination, the data was clear that kids are better protected if they get the vaccine. So their individual health is better protected. We still see kids who get sick. We see kids who are hospitalized, and nationwide, we do see kids who can die from this virus. It's much less common than elderly people, but it continues to be our best way to protect our children. We also know the vaccine can keep children in school safely to really get the education they deserve. So that may be staying in the game, that may be staying in school, because vaccinated individuals don't need to quarantine if they've been exposed. They just need to wear a mask, test 3 to 5 days afterwards, and watch for symptoms. Parents can help protect their children from needing hospitalization or having long COVID. So there's not only hospitalization and death, but there is long COVID. And so again, not getting COVID is your best way to not get long COVID, and vaccination is our tool to do that. Consistently, pediatricians, including pediatric associations, recommend vaccinating teenagers against COVID-19 with the vaccine. So again, speak to your pediatrician, take a look at the data. Dr. Rabinowitz helps to follow all this information. We're happy to share more information as we go. And then medical science, it really shows that vaccines are our best way to keep diseases away from our children, but it also helps to protect our family and community. So many childhood immunizations that we give do a degree to protect our children, but they also help to protect our community as a whole. Our children don't live in isolated bubbles outside of their parents, grandparents, potentially at-risk siblings, and the rest. So being able to minimize their impact helps to protect their whole family, which they need. So just doing what we can to be able to slow the spread. We are asking people to go ahead and self-isolate as soon as that they find out that they have COVID-19 and contact their close contacts. Our contact tracing continues to be limited. Again, if we don't get that data in for a while, it's hard to even start that process, let alone go ahead and outreach. We continue to prioritize the cases that we think will be able to impact the most, but you may not receive a call from a contact tracer, or it may be very late. And as a result, it's incredibly important that you self-isolate and you let your contacts know if you were positive to help minimize the spread of COVID-19. And then adding layered mitigation. I love this picture of these two cuties all excited for school and headed off with their masks and huge smiles underneath it. You can see it underneath there. This graph can be helpful. It's on our website. We can put it in the chat box. But essentially, if you test positive for COVID-19, regardless of your vaccination status, you still need to isolate for those 10 days to minimize your symptom or you potentially spreading it to others. But really what happens if you are a close contact varies depending if you're vaccinated or unvaccinated. So again, vaccinated individuals really just need to watch for symptoms and consider getting a test at 3 to 5 days versus unvaccinated close contacts really need to quarantine. And there's a series of durations depending on if you're testing or not. And then anyone who's sick, we really are still asking for people to stay away from others. The tests are not 100% perfect, but in general, we also don't want to see a big increase in RSV cases like we've been seeing in the lower 48 and other places. So the more that we can collectively do to keep these highly contagious respiratory pathogens at bay, the more that we can all stay healthy and well. So overall. couple other updates of things that have come out. So again, a 3-dose series essentially for those who are immunocompromised. So if you are a solid organ transplant patient or significantly immunocompromised, the CDC is currently recommending people get a 3-dose series. If you already got your 2 doses, consider getting your 3rd now, and that is available as of now, and there's additional information. And then looking forward, there's this conversation about pending booster doses. So we are preparing for offering a booster dose for those who are 8 months out or greater from their 2nd dose. It's not quite time yet. That will kind of start hopefully around September 20th. So we're preparing for that and happy to kind of talk through some of the data as well. So that is where we're at with booster doses at this time. As many of you probably saw, Pfizer did receive a full FDA approval for their vaccine, and this is for individuals 16 and above. And so it's great to see that. There are some, and we can talk through this if people have questions, but essentially this allows some off-label use. It allows them to directly market it. It's out there, and it's got the full approval based on the millions of doses that have been given given at this point. So it's great to see that that is fully approved. If you do get COVID-19, consider getting treated. You may meet criteria for monoclonal antibodies. Our state call line that still can help you find a vaccine, can help you find a test, can also help you find monoclonal antibodies. And again, that's at 646-3322, or talk to your provider. We do have the sheet on kind of the people who are highest risk for severe complications from COVID-19 and who can get monoclonal antibodies under the emergency use authorization for monoclonal antibodies. But we want to ensure that treatment is available to those who qualify across the state regardless. This is our currently only FDA approved treatment for COVID-19 at this time, and the only one recommended by the ISDA. Ivermectin is not. And so there are lots of other treatment options that have been touted in other places, but the FDA has not approved ivermectin for the use of treating or preventing COVID-19 in humans. It was approved at a very specific dose for some parasitic worms and for topical infections, and taking large doses can be dangerous. And so we've been seeing this nationwide. So we just really encourage people to take a look at the data. We're happy to discuss more of this as well, but please don't use ivermectin to treat your COVID-19. Please consider using monoclonal antibodies, as that's where we have the best data at this time. I'm hoping we have more treatment options moving forward, but that's where we're at. We do have a lot of deaths, unfortunately, that we're reporting this week, and we're happy to kind of talk about that a bit further. Part of it has been that because of the cyber attack, our HAVR system has been down and been limited in our ability to look at death certificates that are reported in. But I just want to encourage people, if you've got any questions about the reporting of COVID deaths, to take a look at our website, where we do have a page that kind of talks about this process and how deaths are reported into us and how we review them. It's the same process for COVID-19 as it is for any other disease in the kind of reporting process. So it's been the same the whole time and continues to be the same, and it's put up on our dashboard. We continue to have a speakers bureau, and this we try to get local providers as well. So again, encourage people to consider asking a speakers bureau to come to your local school board or to your council or to whatever group you may have. If you've got questions about monoclonal antibodies or about the COVID-19 vaccine, people have fantastic questions, and we want to make sure that that's answered. I've never met a patient who said that they didn't want to get vaccinated because they didn't care about their health or they didn't care about their community. There's a lot of misinformation out there, and there's a lot of questions, and we want to make sure that that information is accessible to every Alaskan to be able to ask their questions specifically. How to find a vaccine provider? We talked about this before, just with that number, that 646-3322, and we do have interpretation and translation, and we do have ability to help with transportation if that's an issue. So again, here we are at just over 60%. If you happen to be going to the state fair, it's a great time to get vaccinated. If you haven't, they will be here the whole state fair. And there are clinicians standing by at the state fair the whole time to answer your questions as well. There's kind of like a little curtain there, so you can privately ask your question if you just want to ask. So encourage your friends or family, even if they don't want to get vaccinated, but they just want to ask some questions, please come speak to a member of the team and consider getting vaccinated when you're there. So anyway, we will turn it over to questions. Thanks.
All right. So I know that we've touched on the importance of vaccines, but we do have a question here that I think would be great to answer. This participant asks, how do vaccines help end the pandemic? I understand that they prevent hospitalizations and severe illness, but if vaccinated people are able to get infected roughly as easily as those who are unvaccinated, how do vaccinations actually help end the pandemic?
Hey, Joe, you want to take that one?
Sure, yeah. So first of all, the vaccines are protective against infection as well as hospitalization and death. So the more people we have vaccinated, the fewer people we will see with infection. And so it's our best tool that we have to control this pandemic. If we don't vaccinate people, then eventually everybody is going to get infected with COVID, pretty much everybody. And we know that hospitalizations and deaths will also coincide with a proportion of those cases. So there is no better way to control this pandemic than through the vaccine at this point.
And for our Hub team, do we have rates for breakthrough cases for people who are vaccinated?
Louisa, do you want to take that one, or?
Sure. And I guess I would just sort of mention that there is a larger report that's going to come out with a lot more details about vaccine breakthroughs in what we had been calling our monthly severe outcomes report that you can see right now on the website, the older versions. But there are two places where you can see that information right now. One is in the weekly report. It gives the numbers of vaccine breakthrough infections cumulatively up to the current week with numbers of deaths and also hospitalizations. And then you can see that information also in the genomics report. But we're hoping in the next couple of days that we'll have this larger report out, and there'll be a lot more details there that we can share.
One thing that I would also share is that those weekly reports, we're going to have a lot more fluctuation in those numbers just because they're kind of smaller numbers. And so we also want to look at them in these monthly, and that's why we have this monthly report going out. But there is also a recent MMWR from the CDC, which you can put in the chat box, that really looks at LA County and kind of their vaccine breakthrough. We don't have any reason to suspect that like we as Alaskans are fundamentally different as humans, or these vaccines are fundamentally different in our state. And so I think it is important to look at some of this national data on vaccine breakthrough, and we'll go ahead and share that. Anyone else on that topic?
All right, so let's see here. Questions related to travel. Hub team, do you think it's safe to bring 2-month-old on an airplane? This participant shares that they're vaccinated, as is the family that they're visiting, but they're concerned about the effect that travel might have on infants and those who are unvaccinated. And our babies getting COVID with the same severity as other populations? Thanks.
Great question. Lisa, do you want to maybe start with that one?
Sure, I can start with that one. So I think it's a great question. And again, it's back to what Dr. Zink always reminds us. Each person has to really think about your own kind of risk profile and who's in your bubble. As we talk about travel is definitely a risk. If people have to travel right now, there are definitely tools that we have that we know help. So masking is one of those important things. With an infant, obviously, we cannot have them in a mask. And so it's an added risk for an infant. I think similar to all events, there's also the before and after travel that are also at risk. So in the airport, checking in, all of those things, people need to remember that's part of the whole travel experience. Yes, kids and infants do get COVID. A lot of times they do not have as severe of symptoms, but we are seeing kids that do get very sick from COVID. So again, as families make these decisions, you need to keep in mind the risk of that individual traveling, also who you're going to interact with when you get there and who you're going to interact with when you get home in terms of high-risk individuals.
A couple other things that I would add to that. It also depends if you're breastfeeding. So if you're breastfeeding and you're vaccinated, then you're able to give antibodies directly to your baby. So the best thing that you can do to protect your infant is to be vaccinated yourself. Kind of think of it as like daily monoclonal antibody infusions for your baby that you are giving on a regular basis. We've been seeing a lot of kids in the hospital who have had COVID-19. It is not a benign disease in children, and they can be really working to breathe and can be quite sick as well. So I would encourage you to do that. And then as Lisa mentioned, trying to balance that. We do have another provider who is coming in our team, and it's exciting to have her on. Dr. Michelle Nace is a pediatrician and is kind of helping in our school world. Dr. Nace, what would you say as a pediatrician in this space?
Well, one of the things that I would echo also what Dr. Rabinowitz said is you think about what's in your own bubble as well. But the thing that most 2 months old haven't been immunized yet for other things as well, that at age 2 months or right then. So that does put them at risk for other things as well, besides for just COVID. So that's a concern. And the other thing is that we don't know a lot about treating infants with COVID at this time. And so, yes, there have been kids admitted, even in Alaska, under that 1 month age with COVID, as we try to make sure that they're okay and watch them more closely to make sure they're okay, because we don't have the long list of history of treating these younger infants. So it does put you at higher risk. And again, the things you can do is, as parents, be vaccinated yourselves. If you do need to travel, washing your hands and protecting that infant and not leaving them out there, leaving them right up there against your chest is a great place for them to be.
All right, sorry, that unmute button was a little sticky there for me. Dr. Cutchins, could you talk about the timeline for the under 12 vaccinations? Thanks.
Sure, so my best guess is about November. What we do know is that Pfizer met their enrollment early July. So what that means is they had enough people, they didn't need any more. They follow them for 2 months after their second dose, so that puts us any day. They should have kind of the last people enrolled, followed up with, actually probably within the next couple of weeks. And then it's taken them about a month to submit to the FDA and then get a time slot for approval. So I'm still guessing about November. It could be a little bit sooner. It could be a little bit later for kids 5 to 11.
I would say, yeah, we're also starting to hear some messaging. It could be even later based on just needing to expand those trials. So we'll see, but we got to make sure that the process goes through so that no steps are skipped and we make sure it's safe and efficacious. And we'll be sure to let you know as soon as we hear.
And what can we expect in terms of a timeline for boosters? Especially, we have some questions related to travel and people concerned about the need for boosters in advance of holiday travel.
Matt or Kelsey, what do we say?
Sure, I'd be happy to take that. So what we've been told by CDC is that we can expect boosters by September the 20th. But however, we could know earlier. So we're really paying attention to the Advisory Committee on Immunization Practices, the ACIP. They're meeting August 30th, and they have put out their agenda that they are talking about Pfizer. So we're looking towards that meeting to learn more when boosters will be available.
Excellent, thanks so much. A few questions in the chat here about ivermectin as a treatment option for COVID-19. Dr. Cutchins or the rest of our hub team, could you speak to that, please?
Sure, I'll start. I will say that we would all love it if ivermectin was a good, effective treatment against viruses. Ivermectin is used for worms. So a couple things we do know. Early on, it was looked at kind of in a lab, drug versus virus, and it showed to be effective. The trials that have been done looking at does this drug work in humans have not been as great. I will screen share a couple things here. So the FDA, like Dr. Zink said, is really saying we should not be using ivermectin to treat or prevent COVID-19. The Infectious Disease Society America, who are the premier recommendation board for infectious diseases, are also straight up recommending that we should not use ivermectin for COVID-19 based on the current studies. There's more information on here. I encourage people to read it. Really what we're seeing, and I'll tell you kind of the reasoning behind it is, and there's some websites out there that really look fancy and look legitimate and look flashy. But the concerning part for me as a clinical pharmacist is they're recommending really high doses. When we give ivermectin for worms and parasitic infections, most of the time it's once. Some of these sites are recommending, like 4 times that once dose over the course of daily for weeks. So really that changes the safety profile of drugs. I'll put a few things in the chat. I'll be happy. There are a few ongoing trials. They may show that it's beneficial. But so far, all the trials that have been done have shown that it's not a beneficial treatment, but we're going to continue to watch it. And if the trials that are ongoing show it to be beneficial, I'm sure the Infectious Disease Society of America and me, myself, will come out and tell you that data has changed.
And I guess I would add to that, the other thing that we're always thinking about, the FDA and everyone's thinking about, is risk benefit of what we do. And so there is risk of taking ivermectin, and there is risk of not getting other treatment. So monoclonal antibodies are the best treatment that we have now to prevent hospitalization and from you getting sicker. And we have had nationwide people who have taken ivermectin and required hospitalization because of the toxicity for ivermectin. So it is not benign to take it. It has risks associated with it. And if you're deferring other treatment, that is also at risk. The other thing is, if you are not getting vaccinated and hope that you can treat this with ivermectin, you are also preventing your natural immune system to have the ability to take down this virus if it's exposed to it, and essentially using a medication off-label that is not designed for this medication or for this disease, and could potentially put you at risk and at harm. So it's for these reasons, really encouraging people not to use ivermectin at this time for treatment. Anyone else?
You know, I've said it before, viruses are hard to treat. You know, there's this old mantra in viral, infectious disease, mitigation, not medication. So mitigation is vaccine. You know, that's what we know that works, but it's not surprising that we don't have good treatment options. Monoclonal antibodies are essentially, work similar to if you could go back in time and vaccinate yourself a month ago. So they do boost your immune system and kind of work in a similar way. And they also are shown to be highly effective if given early.
Hub team, could you talk about the availability of monoclonal antibody treatment, specifically in rural areas? Where do people find this treatment? Thanks.
So like in the slide presentation, we do have call line. The vaccine call line are able to help people connect. Most of our critical access hospitals around the state do have these drugs for rural areas. Our urban areas are actually where we've had more limitation because we have more people. These drugs have to be given either via IV infusion or subcutaneous injection, and then there is a 1-hour observation period after the therapy. So it's not a tremendously easy drug to give to a lot of people, but recommend people reach out to your medical provider. If you don't have a medical provider, please call the vaccine call line.
A couple other things about it too, it can be given both subcutaneously as well as IV. So some of our most remote and rural areas are giving it that direction. Also working with everyone from Department of Corrections to long-term care facilities to cruise lines on access and availability to be able to administer it in different areas. So please contact your local healthcare provider or use that line if you have any questions. Thanks.
Team, could you do a review of the present state and CDC recommendations related to masking and other mitigation efforts like plastic barriers in spaces like schools?
Anna, that sounds like a perfect one for you.
Sure, we can start with masks. So current guidance is that you should wear a mask when you are in public. You should pick a mask that fits your face snugly, that is made of at least 2 layers of material, and that is comfortable so that you are willing and happy to wear it. And you should change that mask out whenever it is wet or gross or it's been a couple days. I think they recommend every day, but realistically, it's make sure you change it out on the regular, and that's probably adequate. There's a summary of that science available here. There's a couple useful websites. So CDC has a page that's literally named Your Guide to Masks, and you can check that out for sort of a summary of all the different recommendations about how to pick a mask, when to wear a mask, what to do with it, etc. There's also a science brief on community use of masks, and that goes through a lot of the available data on how masks work, why they work, why we recommend what we recommend. And I love this document. I'll post the link for you here in a second. Regarding plastic barriers, so the tricky thing about plastic barriers is that there are a lot of different shapes of rooms. There are a lot of different ways to put up a plastic barrier, and so therefore people are getting really different results in how well they work. There's sort of no reason to think that if you put up a sheet that entirely goes between and creates sort of 2 rooms out of 1, the virus can't sort of transport across that barrier. So that will be effective if you have 1 person on each side of that at blocking transmission between those people. But for the most part, we aren't doing that because if we wanted to have a whole wall there, we probably would have built a room with a whole wall there. And so for the most part, the plastic barriers that we're seeing only block off part of the room. And so those depending on how much of the room they block off and how ventilation works in that space, may or may not work very well. It seems like there have been some studies that have found some benefit. There have been others that have not found benefit. And I think the real takeaway is going to be it depends on your setup. I don't see any reason, or it seems very likely that something like a ticket counter where there's like a very small sort of hole where you guys exchange, tickets and money, and otherwise the two people are blocked off. That seems like it should work pretty well. But situations where the barrier blocks off a much smaller portion of the space or of the shared air between two individuals probably don't work as well. And then there's some other data that indicates, depending on how ventilation in that room is set up, that will have a big impact. So if the barriers in the room really interfere with how ventilation moves through, then they may end up being a net hindrance. I guess that's what I have to say about that. I think a lot more to come on the subject of barriers.
The only other thing that I would add, and I think Anna touched on this a bit, is just ventilation, that continues to be a really important thing in this space, and really appreciate many businesses and schools thinking about the ventilation and why outdoor is so much better than indoor. So I think lots of people are responding to that across the state in responding to this pandemic.
All right, can we talk a little bit more about risks for folks here, whether that's attending a state fair or, for example, working in an office?
Joe, you want to take generally about that?
Sure, yeah. So we know how this virus transmits from person to person. It's through respiratory secretions when you're talking or in the same room with somebody. So, when you're in an indoor setting, CDC guidance is to wear a mask and to do the social distancing. When you're in an outdoor setting, we know that the risk of transmission is much lower. It's not zero, it's just much lower. So if you are still getting really close to somebody who's infected, and especially if you're unmasked, their transmission can happen. It's less likely to happen if you're masked and really close to somebody. I think these are all things that we've been talking about for the last 18, 19 months. It's all kind of the same. The one thing that has changed, though, is that the Delta variant is much more transmissible than prior strains. And so the original strain had a reproductive number of about 2.5. So any individual who got infected was likely to transmit it to about 2.5 other people in the absence of mitigation strategies. Now with this Delta, we're looking at a transmission rate of 5 to 8. So it's much, much more transmissible.
I guess along those lines, I see a lot of questions about the state fair. I don't know, sometimes it seems useful to crowdsource on this group and to speak of what would you consider in that space? I don't know if anyone feels comfortable sharing what they would consider. I guess I will share that, I feel I'm fully vaccinated and I live with a fully vaccinated family. So that makes a big difference. If I'm visiting my immunocompromised dad, I really restrict what I'm doing as well as test prior to that. And going to some place like the fair, having my mask on while I'm there, even though it's an outdoor space, because it can become crowded, or to have that space, and trying to choose times where there's less people there and being able to have kind of that distance for others. And if I choose to have fair food, having it be healthy, first of all, but second of all, space from other people, so that when I am taking off my mask, I can have there. So I haven't been yet, but that is my thought process of what I am thinking about in that space. I don't know if anyone else wants to share their thoughts.
So I'll share briefly, and I was talking to the team about this yesterday. I have an 18-year-old daughter who's heading off to college, and she wanted to go to the fair, and I let her make the decision, but encouraged her at this point, since she's about to head off to college, get tested when she's getting there. I don't want it to affect her starting college. I don't want her to spread it to her dorm, so I encouraged her to think hard about it and maybe consider not going to the fair this year. And it's a hard choice. I mean, the state fair, I grew up in Alaska. It's my favorite time of year. And so these are hard choices for all of us to make.
I can chime in real quick. Dr. Zink, I worked at the fair Saturday. I wore a mask the entire time, ate away from people, but a lot of times I sat down on a bench and someone would come sit next to me, and then I would get up and move. And I am just monitoring for symptoms, and if I have any symptoms whatsoever, then I'm going to get tested, and I'm being a little bit mindful of being close to people in my household as well, even though everyone's vaccinated. Thanks.
All right, thank you so much, Hub Team, for sharing your experiences. All right, perhaps this one is for Dr. Demain. We have a participant who shares that their adult daughter was told by her allergist that she could have an anaphylactic reaction to the vaccine. What are the risk factors for an allergic reaction to the vaccine?
Thanks for the question. I was just typing it as you asked me, and I will finish typing my answer. But the only contraindication to the vaccine is being allergic to components within the vaccine. And if we're talking about the mRNA vaccine, which is the one that was associated with a very rare risk of anaphylaxis, about 2 per million, it appeared polyethylene glycol is the suspect component. We don't know that that's the component, but that's the suspect component. And that's found in many things, certainly laxatives and other medications, and also foods. Most commonly, the most common reporting of people having anaphylaxis to that is when they're going to have a bowel prep and they drink a liquid to help clean out the intestines. But anyway, that's the only contraindication. If the polyethylene glycol is not in any other vaccine, so even if somebody had a bad reaction, let's say to a flu shot, it really has nothing to do with the mRNA vaccine or the Johnson & Johnson adenovirus vaccine. So people that have a history of allergy or asthma, the thing we do recommend is a longer observation time. About 38% of people that have some mild immediate reaction do have history of allergy, so they may have a little bit higher risk of some mild symptoms. But again, anaphylaxis is rare, and I would encourage that your daughter speak to her doctor about that again. That might have been misunderstood in what her doctor said. So the answer really is get the vaccine, be observed for 30 minutes, and that should be it. So I think the risk otherwise is probably not much greater than the general population.
The other thing that I just might add along those lines is I think from an outside perspective, sometimes doctors are doctors and we're all the same, but I am definitely no Dr. Demain, and he is an allergist and immunologist. I'm an emergency medicine. Joe's an epidemiologist. We all have different ways of thinking about this. And we know that we go to a hand surgeon when we need a hand. If you have a significant question about allergies, immunology, and what this looks like for the vaccine, please see an allergist and immunologist. That's their area of specialty. That's what they know. And we always, recommend considering a second opinion if you're getting something that doesn't seem right to you, or if you have a lot of questions. These questions are really important, but your primary care doctor, your orthopedic surgeon may not have as much information as an allergist and immunologist in this space. And so I would encourage them to really get that specialist opinion if they've got questions and concerns. Thanks.
All right, thanks so much. So I am noticing a couple trends in our questions here. We still have quite a few related to vaccine breakthrough that I'd love for us to get to. And then we also have some questions around timing with the booster doses. So we'll go ahead and start with some of the questions related to vaccine breakthrough and then move on to boosters here. The first one related to vaccine breakthrough. Is it true that 21% of COVID deaths reported from July 10th to August 14th are from vaccinated individuals?
Louisa.
I don't think so. If we look at the weekly report, I think we've had, I guess I'll have to look at the numbers, but I don't think 27%, that seems very, very high.
Yeah, so we pull up that one. I guess I also say, like in the weekly report, like we may have like boluses of cases or deaths. And so it's really hard to look at a weekly number and state that they're clear trends, particularly for something as small as death. So as Louise is pulling up that one, I would just really caution people. I've been seeing a lot on social media where people are taking our individual weekly reports and making these large generalizations about them on really, really small numbers. And that's why we would highly encourage you to take a look at our monthly reports, where it takes into account a lot of the limitations, including the time it takes for deaths to be reported into us. Louisa?
Yeah, sorry, I'm not as fast as you.
Sorry, I was trying to stall, give you time.
One thing I could do, it seems like people are still a little bit confused about what's happening with vaccine breakthrough and vaccine effectiveness in general. So I could provide just a really quick overview of what's happening scientifically on that front to help folks a little bit. So I'm just going to take you through a couple of quick articles. And this is one that I've gone over in the past, but there are some new people on the call this week. And so I just want to review this MMWR that came out that showed the estimated COVID-19 outcomes prevented during 120 days after the first dose of either the J&J or of the Moderna, or the mRNA vaccine. This is per 1 million doses administered, and it looks at benefits and harms of vaccination. Here's what you see. For the Johnson & Johnson, it's broken down by females, males, and for an mRNA, it's broken down by females, males, and by age group. You can take a look at your specific age group and look at whatever vaccine you're interested in and see per 1 million doses, what are the expected benefits and harms of vaccination? This gets to the very first question that came up today on the call, which is, show me the data, the proof that these vaccines are really helpful in preventing or curbing the pandemic. So let's just look at one group here. Let's look at females in the 50 to 64 year age group. Here's what you expect to see with per 1 million doses of an mRNA vaccine administered. You're going to prevent 17,500 cases. You're going to prevent 1,700 hospitalizations, 375 ICU admissions, and 125 deaths. And you expect to see 1 case of myocarditis. This table is really helpful for, I think, convincing people of the benefits of vaccination, how they clearly outweigh the harms, and how these vaccines can prevent so many cases of COVID, as well as hospitalizations and deaths. Now let's take a look at the rates of hospitalization among people who have been vaccinated versus those who have been unvaccinated. What we see is the rate of infection is about 5 times higher in people who have been unvaccinated compared to people who have been vaccinated. And the risk, I should say, of hospitalization is almost 30 times higher if you're unvaccinated. This is the study that Dr. Zink just mentioned. SARS-CoV-2 infection and hospitalizations among persons aged greater than or equal to 16 years by vaccination status in LA County. This one just came out. Now, let's take a look at this. What if you have had prior SARS-CoV-2 infection should you get vaccinated? There's another study that just came out showing that people who had prior infection and decided not to get vaccinated were at more than 2-fold increased risk of reinfection if they didn't get vaccinated compared to those people who wound up getting vaccinated despite the fact that they had SARS-CoV-2 infection. Now, here's the last one. This one just came out this week, I think. Yeah, this week, sorry. So this one looks at the effectiveness of COVID-19 vaccines against any SARS-CoV-2 infection among frontline workers by Delta variant predominance and time since full vaccination. So here's what you have. So if you're looking at the period from 14 days to 119 days after full vaccination, the vaccine effectiveness during this time period, December 20th through August 21st, was 85% at preventing SARS-CoV-2 infection. And then 120 days to 149 days, it dropped down to 81%, and greater than or equal to 150 days after full vaccination, it dropped down to 73%. So what we're seeing is waning immunity. And that's why CDC is saying, hey, and ACIP is saying, hey, it's time for a booster dose. We have evidence suggesting that the immunity is waning over time, so let's give people a booster dose so their immunity bumps back up. Now, one of the things that we're seeing is that during the pre-Delta variant predominance period, the vaccine efficacy was 91% overall. And during the Delta variant predominance period, the vaccine efficacy has dropped down to 66%. That's probably due to a number of factors. Number one, waning immunity over time. A lot of those people were vaccinated, months and months ago. And then also number two, we know that Delta variant is much more transmissible. It's probably twice as transmissible as the original strain. And there's also some evidence to suggest that it may have the ability to evade prior immunity to some degree. So those are all factors contributing to that decreased vaccine efficacy.
I think the only other thing that I would add to that too is ask vaccine, like we would love it if they could be perfect protection for you, but what they do is they really decrease your risk of getting really sick and decreasing your risk of spreading it to others. So I keep reflecting on what this Delta variant would look like if we did not have vaccines. And so thinking about all of the people who are immunocompromised and elderly, it's not uncommon to be in the emergency department and see someone who's really struggling to breathe and their spouse is vaccinated sitting next to them and their spouse is fine. And that patient who's unvaccinated is super sick. It's just striking. So while it's not perfect, we see vaccine breakthrough cases, we see vaccine hospitalizations, we see deaths. It still is doing an amazing job at tempering this surge, minimizing the surge on people getting sick, hospitalized, and dying. Should I turn it back to you, Louisa?
Yeah, sure. I mean, I guess, this is one of the reasons why we're having, why we're sort of putting together more information in a vaccine breakthrough report, because there's some really important things to take into account with regard to vaccination coverage and age. And so there are some adjustments made, as you do in epidemiologic studies, to take into account some of those things. I just was looking at, in the weekly report, we just give those kind of quick figures, and there are 8 vaccine breakthrough deaths in the same time period of 137 total deaths. So 8 were vaccine breakthrough over 137. There were 74 hospitalizations over 141 total hospitalizations during that time. So, those numbers are still in the 90s of people who are unvaccinated, people who are dying and who are being hospitalized. That information, I had put it in response to one of the questions about where you can find the weekly summary. That other report that we're talking about is hopefully coming out a little bit later on this week, and we'll have some more of the sort of granularity of that data presented for people to see. Our hope is to get that out monthly as well, to update those figures and have more discussion on it. There are some changes, as everybody knows, with Delta and how that has been interacting with protection with vaccine. And I think that's something that we're watching nationally. It's being watched and, is behind some of those decisions on booster doses and what have you. So I think those I actually don't see on our website the most recent weekly summary, but you can see the past ones, and I'm sure that will be up there maybe later on today.
The only other thing that I would add to that too is there's this age adjustment factor that we also have to take into account. We know older individuals and those who are immunocompromised were more likely to get vaccinated, but they're also more likely to have terminal cancer or other things that may be making them very sick and ill as well. And so again, we're just sharing the numbers that are out there, but there are lots of caveats into these numbers when you start to kind of dig into them and what they specifically look like. So I just wanted to kind of highlight that factor. And I think that's part of where you're seeing this difference between the hospital saying, man, we're just seeing such young, sick people in my hospital all the time, yet we're seeing, some vaccine breakthrough cases of people passing away. Well, they may be in hospice and they passed away, yet we report it just like we do the other ones, versus the young 30-year-old maybe in the hospital for a month and being seen many clinicians and taking a lot of resources within the hospital at that time. So there's different ways to look at this data. Our goal is to be transparent and honest and make sure you've got the information there. But there are caveats, particularly with things like age and vaccination rate, that also need to be taken into account.
Yeah, sorry, Anne, I thought of one more thing just as you were speaking about that, which is one thing that we really don't know is what is maybe the difference in populations for people who are choosing to vaccinate, are choosing to be tested super early and then sort of present and have their medical situation sort of taken care of. One thing that makes us nervous is maybe somebody who is not as likely to be vaccinated is maybe not as likely to get tested or sort of take care of their health as early. And so maybe that means they present later to a hospital in a time when they could have really been identified early and maybe had some sort of treatment to help them not progress that far. So those are some things that make us worried. Maybe somebody has reasons for choosing not to be vaccinated, but please, if you have symptoms, get that identified early so that you can have treatment early.
All right, one more question here about vaccine breakthrough. So people who have been vaccinated and experience breakthrough, what's their risk of getting what we call long COVID?
A great question. I don't know, Joe, you want to take that one?
So long COVID is still a possibility among people who have breakthrough infection. We don't know yet for sure what proportion of vaccine breakthrough cases are associated with long COVID. I suspect it's going to be much lower than regular cases of COVID that are non-vaccine breakthrough, but we're still awaiting good clinical studies, epidemiologic studies to really demonstrate what the risk is.
All right, thanks so much, team. We've got about 11 minutes until the end of our session and quite a few questions to still get through. So just want to put that in your minds here as we proceed. All right. I'm seeing a lot of questions in the chat talking about boosters and then also the third dose for immunocompromised folks. Perhaps our hub team can speak to the difference between those two things and then some of the timing related to when folks should anticipate getting their third dose.
And Dr. Rabinowitz?
Sure, I can start with that. So currently, as Dr. Zink mentioned, third dose is available for moderately severely immunocompromised individuals. And a great way to think about that is that their primary series really now is 3 doses. So in the studies, some of those individuals didn't get enough protective antibodies after their initial 2 series. So studies showed that if they got a third dose, they significantly could increase their immune response. So we are encouraging anyone who falls into those categories to please get your additional or third dose. If you're unclear, speak with your healthcare provider. So that is something different than a booster shot. So as Dr. McLaughlin showed us in the data, we're starting to now see that there is a waning of immunity over time. And so we're looking at booster doses potentially happening September 20th. The data is still being reviewed by the ACIP and CDC. If they do authorize those, most likely right on September 20th, we can start offering boosters to those that qualify. Currently, the thought is if you're 8 months out, that could change a little bit when they're approved, but 8 months out after your second dose of your mRNA vaccine. There's some questions in the chat about Johnson & Johnson. Those started being done in March in the US, so they're still looking at that data and hoping to give us more guidance in the next few weeks. Johnson & Johnson did release some of their data today that looks like a booster will also augment those individuals that had Johnson & Johnson or Janssen. So we will continue to update everyone. At this point, the state is planning for boosters. We're gearing up to make sure that we have boosters available for those who qualify. There's a few other questions in the chat about the formulation. This is the same formulation as the initial vaccine that you received. And the reason for that is that, you know, as we've discussed, these vaccines are still working. They're working for severe disease, hospitalization, and death. And those are the things that we're very concerned about. So again, start figuring out when you did receive your second dose of your series. So as more information comes out, you'll be ready to get your booster dose.
Thanks so much, Dr. Rabinowitz.
You know, one thing I would just add to that real quick, I want to acknowledge how confusing this is. That the timing of how this information has come out has caused so much confusion. And I really feel for all of you out there, because it is a lot to tease through all of these media stories and information that is out there. So really at this point, we are just focused on those immunocompromised individuals getting that third dose, as Dr. Rabinowitz mentioned, to complete that primary series. When it is time for boosters, we will make sure everybody knows that. We will do a ton of messaging, make sure all of our providers know that. So it will be loud and clear when it is time for boosters, and we are calling you all back in for those who had been vaccinated within that 8-month or 6-month, whatever that time period looks like. So do not fear, you will know when it is time for this, and we will make sure that it is clear as possible when we get to that moment.
Thank you so much, Kelsey. Dr. Rabinowitz, you did touch on this, but we did have a question explicitly asking if there was a difference in the Pfizer vaccine between its EUA authorization and the fully approved. It's my understanding that those are the same vaccine. Could you confirm?
That is correct. So We know that the vaccine went through rigorous scientific process to get its EUA, and now we can feel confident that we know it's safe, effective, and that the manufacturing process is also very clean and appropriate. So that's kind of what this final licensing shows us. So we really want to encourage people that were waiting for the final approval. It's here. We know these vaccines are extremely safe. They're effective against what we talked about, severe disease, hospitalization, and death. So please, if you've been on the fence, go get vaccinated. This Delta variant is very transmissible. And we talked about, earlier, why get vaccinated if it's so transmissible? Every time we stop an infection from occurring, it's less of a chance for this virus to mutate and change and get smarter. So please get vaccinated.
And just a reminder, 907-646-3322. That is your one-stop shop for testing, vaccine, or monoclonal antibody on where to get it, who needs it, and how to make this all happen. So our team is here 7 days a week to support you.
Excellent. So for folks who are immunocompromised and looking for their third dose, do they need to provide evidence of their conditions? And yeah, that is the question. Do they need
That's a great question. And the CDC provided guidance on this specifically. So we recognize that this group of moderately severely immunocompromised is an at-risk group, and we really want to limit any barriers for them receiving that third dose. And so they just need to come in and self-attest that they're immune compromised. They don't need a doctor's note or to provide any documentation of that. Again, we encourage people, if you're unsure if you fit into that category, do speak with your providing physician or clinician.
All right, and so recommendations for booster shots after 8 months, do those apply to folks who received Moderna and Pfizer vaccines?
So that's correct. Currently, we're looking at boosters for mRNA. As I discussed, the J&J data is a little behind because that rolled out later in the United States. And so that data is being looked at currently. And we expect guidance for the J&J as well.
All right, thank you so much, Hub team. A couple questions here related to businesses and the impact of COVID on staff and general resources. What can business owners or other folks access for guidelines around COVID?
Well, I bet we could all chop in there. There are a lot of guidelines out there. And so Anna's got some great resources, both CDC. I would also just highlight that we have a large group gatherings team and the Speakers Bureau group. And so we can help with large group gatherings to kind of think through what that looks like with tools and resources there. And the Speakers Bureau can talk about like, what does this look like? And what is, how do you prevent COVID or minimize its impact on your event? But every event is a little bit different. Every business is a little bit different. And the tools that we have are different depending where you're at. Anna, what else would you add there?
So there are many, many kinds of businesses, and there are many services that they provide. And so recommendations are going to vary widely depending on what your business does. So it's hard to give super general recommendations. CDC has like a very large chunk of their website that is devoted to this. Sorry, I just realized. Let me open it up. So if you go to the workplaces and businesses section, you will find tons of different sections on stuff you can do ahead of time, on how to handle employee activities, all kinds of stuff going on here. And I will post that link there. But otherwise, there's so much difference between if you are a restaurant or some kind of a sort of a shopping sales type setup, or if you are a business that doesn't see clients on site. Like there are just so many different ways you could do this that I don't want to bog down the call.
All right, thanks so much, Anna. All right, well, we're nearing the close of our session. Any further updates from our Hub team?
Yeah, I guess I just want to say thanks again for coming to these. There's a lot of great questions in the chat box. The team's been trying to respond there. We really appreciate you all taking the time. People are frustrated. This is hard. I think we all wish that COVID was over a while ago. I don't think anyone is not in that space. The public health team is working hard to support you and the questions and concerns that come in. The healthcare team is working incredibly hard at serving people on the front line. And I know that you all are trying to figure out what this looks like for, your family and your community, and the teachers are figuring this out in schools in that space. And so I just really want to encourage Alaskans to continue to have space and grace with each other and kindness and hope. So this is not going to last forever. This will get better. And this is hard right now for so many out there. And I encourage you to reach out to someone who might be struggling in this space. Maybe a kid who's going back to school for the first time. Maybe it's a nurse who's been really struggling in that space and what it looks like. Maybe it's someone who does not want to get vaccinated and feels like they are just getting pushed and pulled from every direction, and offering compassion to them and hearing their thoughts and questions. So I just wanted to end on a message of hope that we will get through this together. Alaskans pull through together, be it bad storms or earthquakes or hurricanes. This is our current surge, and we will be here next week. We'll continue to answer your questions, and we will see you soon. Thanks.
Thank you so much, Dr. Zink, and thank you as well to our hub team for your expertise and time. And as always, thank you so much to our participants who make this such an engaging and dynamic session. I do have a couple of ECHO updates. So the Center for Human Development and the state of Alaska are presently conducting a survey on access on the COVID-19 vaccine for people with disabilities. And they'd love to hear from adults with disabilities, family members or caregivers, and disability service providers. If you could take a moment to complete the survey or share with people you know, we've included a link to that survey in the chat. Again, thank you for attending today's Public Science Echo and for joining this dialogue. Our next session in this series will be Wednesday, September 1st from 12 to 1 p.m. And a reminder to please visit the shared box folder where you can access videos and resources from all echoes in this project, including today's. All right, take care of yourselves and each other, folks, and we'll see you next week.
Bye-bye, everyone.